Hello and welcome to the Back to Basics podcast. This is a podcast where I, Jason Seitz, a firefighter paramedic RN, and my brother, Christopher Seitz, an ER physician, talk about complicated medical topics, and we break them back down to the basics to make them easily digestible for you.
Mainly for us.
Yeah, and then we just produce that, and then you might glean something from it.
Right.
Or laugh at our idiocy.
Right.
One of the two. Couple announcements. If you want to CE for this and you are an EMS provider, go to guardiancme.com. If you know the marketing guys at Dr. Pepper, specifically Diet Dr. Pepper, please put us in touch with them because we'd like them to sponsor. If you are a nurse or you know nurses that also need free continuing education, have them check out guardiancme.com very soon. We will be releasing nursing credits that will be absolutely free for all nurses coming up very soon here. We should have our accreditation within a couple weeks. So that's very exciting stuff.
Yeah.
You can also tune into our other channel, the Collaborative Practice Podcast, to check out interviews that Chris and I, or just Chris, has with up-and-comers in the technology medical space, in the business medical space, and it's all about like collaboration in medicine and how we can come together and advance medicine and advance patient care, access to patient care. So
Absolutely.
you can check out those episodes.
So today's topic is titled Breaking Bad Badly, and we are going to be talking about meth, amphetamine, and other non-opiate illicit drugs.
Specifically uppers, because mainly to cover downers and every med ever is going to take forever.
Right.
So I kind of honed in on more like amphetamines and other stimulants in this one that are non-opioid, because opioids get all the attention, right? Like because of the opioid epidemic, that's a big attention-grabbing thing that we pay attention to. It is the number one cause of like illicit drug death right now. But there are lots of areas in this country and in others where it's not the number one cause of death, and really meth is. So like if you look at like the California like Valley area and stuff like that, anything basically on the border of Mexico, meth is huge.
Not even, I mean, like even in Michigan. So like I did travel medicine as an ER doctor for a long time, and like it amazes me, it's going to sound weird, but it amazes me how little methamphetamine comes up in my daily life and how much it came up in my professional life. Like they're like, especially in like opiates are kind of expensive. Mm-hmm. So like typically like opiates and stuff like that, like you'll find in more, I mean, this is a blanket statement, but like in more like well-to-do areas, people who can afford to go to the doctor and get it prescribed first, and then later on, you know, they
if that's the route they get to it.
Yeah, but it typically is, right? I mean, that's where the opiate pandemic came from, was physicians overprescribing. Like, but when we go to like, when I worked in like rural areas or less well-to-do socioeconomic like methamphetamine is actually like a big problem.
Well, and cocaine, crack cocaine,
right?
Specifically, you know what I mean? It's not necessarily the refined white powder stuff that you're going to see in fancy New York, you know, areas, but yeah, like crack cocaine is cheap and fairly easy to make.
Right.
Based on doing the research that I did last night for this episode, I could make meth. It was like I looked it up on Google, and
maybe
like they tell you everything that you should pick up at your local drugstore. And the article's about like how bad it is. It's like, I don't know, maybe not give us the keys to the kingdom.
Yeah, interesting.
So
maybe we can do a YouTube video on
making meth and what can go wrong with that.
A science experiment.
Exactly. So we're going to kind of define and describe the differences between the effects of dopamine, norepinephrine, and serotonin in the body.
Seems like a lot.
Because those are the chemicals that these meds are going to manipulate, right? We're going to distinguish between the signs and symptoms of stimulants and depressants. And then we're going to identify treatment paths for patients suffering from stimulant overdose or misuse. I'm just going to call it misuse because, like, I get really annoyed by the definition of like OD. Like people are like, you can't OD on marijuana. You can't OD on like.
Yeah, misuse is a good term. I mean,
misuse is the best way to put it, because the thing is like, if it doesn't have a recommendation, like an FDA recommendation to use, any bit of it would technically be kind of an overdose.
I mean, you could anything. It's the whole thing, like everything in moderation. But like any medication, you can misuse Tylenol.
And not overdose on it in the sense that you'd think like no one's going to be like passed out in an alley.
But you can overdose on Tylenol.
Die from Tylenol.
Right, yeah.
You know, so what are we defining overdose as? Like a death caused by it? Like you're in a shock or a, you know what I mean? Like a little bit of cocaine is an overdose of cocaine in my opinion, because it is
a misuse.
Yeah, it's a misuse, right? So, cool. So first thing that I want to touch on, we always try to touch on this first, is just like scene safety if you're an EMS provider and you're out there, or even if you're you're a clinician in a hospital setting, seeing safety based off of just like the effects, the aggressiveness that these patients can have sometimes. So if you're in the field, I almost said if you're a field operative, never use that phrase in anything.
You are, and you're listening to this podcast. That's pretty awesome.
Sweet.
And send us a question.
Call. We'll talk to you on the CPP. So, but if you're in the field, the biggest danger when it comes to the creation of this stuff is that like meth labs are very toxic and dangerous.
Right.
And we'll talk about it a little bit more when we talk about amphetamines specifically, but basically those places can blow up pretty easy.
Mm-hmm.
We'll talk about why. But be on the lookout when you're discussing with your patient and when you're in your patient's environment and you're ready to take them to the hospital for things that would clue you in to an upper addiction or a cocaine use or amphetamines or MDMA or anything like that, right? If you're at like a techno concert, you might think that's why they're acting a little bit loopy. Maybe it's like MDMA. Mm-hmm. If you're in literally a crack house.
Weird blanket statements about like certain concerts and what.
No, I'm just saying use common sense.
I know.
If you're at like a electronic, what's the word I'm trying to think
music
of?
festival?
Techno would not be the word.
EDM.
Thank you, Jamie. EDM concert, then there's a lot of MDMA use there. Like Molly's very popular at those.
Yeah.
So just let your environment clue you in onto your patient's condition. It might not be hyperglycemia that they're acting loopy. It might be that they took MDMA. Mm-hmm. So, cool. Be safe. Let law enforcement handle that kind of stuff too. Uppers in general, let's talk about stimulants and psychostimulants and what they manipulate. So there are 3 chemicals that they manipulate. Why don't you tell me what they are?
Dopamine, norepinephrine, and serotonin. And the reality is that like kind of all medications affect those 3 things. Not all medications.
You shouldn't say that.
Not all medications, but I mean all drugs that are like misused have to do something with all those things. Yeah. Like, and I will say like maybe not all. A lot of the medications out there have to do with regulating serotonin, norepinephrine, and dopamine. Whether to bring them up, whether to bring them down,
anything that's going to be mood altering is going to involve those 3 chemicals.
Antipsychotics, right? Like antidepressants. These illicit types of drugs. I mean, they all manipulate.
Depressants and stimulants will both play on both sides of this.
Right.
So
exactly.
Yeah. So let's talk about what they are. Dopamine. Dopamine is basically your reward center drug. So whenever you do something good and you feel good about it, that's a dump of dopamine in your brain. That's where Chris, please don't say it. Just I know you're ramping up to the whole like social media. You get dopamine dumps when you, and then you make a joke about like
it's not a joke. It's true.
Fans or something.
No, it's true.
Okay. No, I believe it. Yeah, but like
they actually have measured. I'm gonna do it. Now they've actually looked at the research of like alcoholics who, like the dopamine dump they get from like having their first drink is similar to the dopamine dump that a teenager gets by getting likes on Facebook, which is why a lot of like
it's addictive.
Yeah, it's addictive. So you get addicted to that dopamine dump. That's why you keep swiping, keep liking, and literally like the tech companies like know that and play to that a little bit.
Exactly.
So.
Well, that's what, especially like gambling, like slot machine games and stuff like that are very much designed to chemically manipulate.
Every time you pull that lever, you get dopamine dump. Same with like sugar can be this way. Like people can get dopamine dump for sugar, so that's why they like eat too much sugar. It's also why like McDonald's put like if you look at like the way McDonald's developed their like hamburgers and stuff, like the bread, like they put like certain levels of sugar and stuff in there to like cause dopamine dumps.
Literally a happy meal.
Yeah, but like, but for real, like it's I mean, so
yeah. So, and there's nothing wrong with dopamine. It's not a bad thing. No. Too much of anything is a bad thing. Too little of anything is a bad thing. So, but this is your reward center. Basically, dopamine effects. If there's a lot of it, you'll have effects that are you'll feel euphoric. You'll feel energized. You'll feel horny. You'll have trouble sleeping because you're so energized. And then you'll have poor impulse control because of the pleasure, and you'll also be more aggressive. Could be more aggressive based on that. So your inhibitions kind of go away, right? Because you're seeking. So this happens. I mean, you get dopamine dumps when you exercise. There's nothing wrong with that.
There's such thing as a runner's high, right?
Yeah. When you have too much of that, you're going to start seeing those effects, and your body needs ways to balance those effects so that you're not that way all the time, right? Norepinephrine specifically you think of epinephrine, it increases heart rate and blood pressure, right? So it's more of a fight or flight response. So because these drugs also affect that side of things, it's not just mood altering, and it doesn't just get you a high, it can also put you in an area that's very dangerous for, brain hemorrhage or cardiac conditions because your heart rate's spiking and your blood pressure's spiking.
I mean, like people who like misuse and overdose on cocaine can have heart attacks from it, right? Like you can have hypertensive emergencies with people who are on too much methamphetamine and things like that. So yeah.
Right. And then serotonin affects your mood, your appetite, your sleep, other things too, sexual arousal. It usually gives you an elevated mood, serotonin would. So things that play up more on serotonin, that's a blanket statement. I don't want to necessarily say it, but there are uppers that essentially are both stimulants and hallucinogens, and those can get a little bit dangerous and play a little bit more of a role with serotonin. But serotonin is going to be more of your mood stabilizer, so makes you feel good, not just energized, but you feel good. Cool. So then the other thing I want you guys to understand is basically antagonists and reuptake inhibitors. Okay, so when a chemical is dumped into our brain, like for instance dopamine, we have reuptake mechanisms that basically use that dopamine and pull it out of that area where it's binding to things. Eventually, reuptake will pull that dopamine and store it away where it's not being used or the effects aren't taking place.
Well, think about it too, like at the end of a neuron, right? So dopamine, these are like hormones in their own way, but they're released from neurons. So like the neuron releases dopamine, dumps dopamine into that synaptic cleft between it and the next neuron, or the next, whatever, whether it's a neuron or muscle tissue, whatever it might be. Something has to grab all that dopamine and get it out of there so that you can have it
reabsorb it,
right? Yeah. So you can like these stimulants will dump dopamine, will cause these neurons to fire and like unleash dopamine.
And then when dopamine is out there, dopamine is now binding to dopamine receptors to get the effect on the body.
Right.
So two ways to attack that to prevent dopamine from being out there. I can either block those receptors so dopamine's just floating around doing nothing.
And that would be an antagonist, right?
An antagonist.
A dopamine or norepinephrine or serotonin antagonist would be something that blocks that dopamine, serotonin, or norepinephrine from binding to whatever its source is, right?
Or I can increase the reuptake, which would allow the reuptake to happen more often and then stores it and then they can't bind.
Right.
If I want to keep dopamine out there, and in the case of stimulants I do, and don't think necessarily stimulants are always bad because we use stimulants all the time to treat ADHD and things like that. So if you have a stimulant in general, you're trying to get more dopamine in that cleft because maybe Chris's body reuptakes dopamine too soon and now he's depressed all the time, right? So we want to keep dopamine out there so that he can battle his depression. I'll use something called like a reuptake inhibitor, which will prevent the reuptake of that dopamine and leave it in there. Or you could increase dopamine by...
Right.
So we're not going to do that, but you could increase the production of dopamine and the binding of it.
Yeah, and I don't think you want to get into like necessarily the mechanism of action of every single one of these.
Correct.
So basically what we're trying to say is that like some stimulants either cause you to dump dopamine or to not reabsorb it, say with serotonin. So there's different mechanisms of keeping these chemicals out there so that they can have their effect.
Most of the illicit drugs that we're going to be talking about today are very potent reuptake inhibitors. So they prevent the reuptake of dopamine, so the dopamine is binding and in your system longer.
Right. And interestingly, a lot of the medications we use as anti-anxiolytics or antidepressants like serotonin are like SSRIs, serotonin reuptake inhibitors. So like even like medications like Celexa or venlafaxine, like these medications are meant to have the same effect, to like keep dopamine and serotonin, these different things out into the synaptic cleft so they can have their effect.
And that's much safer when you're dealing with serotonin because serotonin doesn't have effects of euphoria. It's not as highly addictive. So giving you Celexa for depression is a lot safer than what we used to do, which would be like basically give like cocaine.
Because there is really not a dopamine reuptake inhibitor that we prescribe because dopamine, again, has that addictive effect of those dopamine dumps and stuff. So, yeah.
So that's how, and we'll get into kind of the history of like cocaine and amphetamines and stuff like that. But that's how it was created. It was created and designed to, okay, we can keep our energy up, but it also helps fight depression and stuff like that because that reward center. Why am I so hooked on it though? Well, because dopamine's a very addictive chemical because it's the reward center. Cool. So dopamine antagonists, examples of dopamine antagonists would be things that we would treat like antipsychotics with, right? So, where we would treat I almost said psychotics. That means like negative connotation.
I mean,
people with psych conditions,
right,
you know, people that are psychotic, we would use antipsychotics on, and they would be dopamine antagonists, which basically prevent that dopamine from being out there so that there's not these, you know, strange mood swings and this aggressiveness and things like that.
Hallucinations.
Right? When we like calm somebody down or we snow somebody, a lot of times we're using dopamine antagonists in order to sedate them because we're stopping dopamine from being in there and making it reuptake more. Cool. So let's talk about cocaine.
It's great.
No.
You're like, no, wait. So cocaine's actually very interesting because cocaine obviously comes from the leaf, right?
The coca plant.
The coca plant.
Discovered in the Andes. Is the Andes Mountains?
Yeah.
In South America?
Yeah.
It was chewed by like the local.
Well, it still is.
Yeah.
It still is in South America. There's a lot of like the way we use caffeine in America, right? Like people have multiple cups of coffee today. A lot of the natives and tribes in like the Andes and like South America, like will just chew on cocoa leaves throughout the day, especially like they're like climbing up and down a mountain to do their farming and stuff. Like it keeps them energized, keeps them up. It really like the way they use it by chewing it naturally like that is exactly the same way we use caffeine.
Yeah,
it's like having multiple cups of coffee.
It's mild effects, yeah. Then what happened was people were like, cool, let's create
do more
a
of it.
synthetic version of this and like distill it down and then add it and then snort it as a powder.
And I always imagine that like it was like some guy who was like essentially trying to create his own version of pre-workout. You know what I mean? Like he just went a little too far.
Sure.
You know? Or the pre-workout worked so well. I mean, like in a similar fashion, like there are men who abuse pre-workout because it's got like lots of caffeine and lots of other things in there that again have it's a stimulant effect, right? So
pre-workout kind of the pre-workout that has, and I'm not looking for feedback on this, people. Okay, I'm not anti pre-workout. Right. I'm just saying that I personally don't like taking pre-workout that has any like thermoregulation changes because the idea of like heating your body up just scares me. I don't know, it just bothers me.
So it's actually funny there, and I forget what I think it's the alanine or something that's in it. I mean, alanine's not even the thing, but anyway, there's something in it that like almost like gives you like a tingly sensation. So like I've taken pre-workout and I'll get a good workout in. Like I can push a little bit more. I can like get an extra set in, but like my face will tingle and like that's like a normal side of it. I don't like it though. I just don't.
Right. And what would happen a lot of times at the firehouse is that like people would be like, all right, like we're working out today. So like I'm gonna take my pre-workout and like let it sit for a half hour. Well, then we get a run.
Oh, so they're just like hyped up.
So they're just on the run. They're like, like it's like they're like hot. Their skin's hot.
Right.
Their workout's ruined because it's gonna wear out by the time they're back. So like I just kind of stayed away from it because it freaked me out a little bit. But
anyway, we're not saying that pre-workout is like cocaine, but we are in the sense that like the stimulants are stimulants, right? Like we can judge certain ones if we want to, but they're all the same.
So if you take a coca plant and you basically add some synthetic processes to it, and it's not synthetic, it's a natural process where you basically like boil it down the right way. In layman's terms, you can create cocaine. And there's like lots of ways to make cocaine. There's like the refined rich people powder that would be like snorted. That would be like more pure white, like cleaner cocaine. And then there's like crack cocaine, which would be basically like crystals. That are like glassy crystals that can be anywhere from like white to brown, you know, depending on how well they were created. You know, Breaking Bad is all about like
that's meth,
having the perfect crystal meth because it's such a clean, you know what I mean?
Right.
We'll talk about it, but it's similar process in the sense that it's rock versus powder. And then what users will do is they'll boil that down, like that's where you see like the spoon, right? They'll like boil that down and then they'll either inject it or. I mean, you could drink it, but it doesn't have a very good effect. There's a lot of different ways to do cocaine, but injection is typically, if you're using crack, injection is going to be the most used. So free-base crystal versus pure white powder. Cocaine has a half-life of about 60 minutes. That doesn't mean you'll have a 60-minute high. You can have longer than that, but it's half-life, meaning the time it takes for half of it to be like consumed in the body is about 60 minutes. Where meth amphetamines and any amphetamines really differ from cocaine is that the half-life's like 10 hours.
Oh, wow.
So amphetamines, working in that with that reuptake system, they inhibit that reuptake for way longer. So you have a way longer high, but also you have all of the negative effects too for a longer period of time. Your blood pressure, your heart rate, all of that is way higher, so that you're more likely to produce, long-term negative effects, and you're kind of in more danger for a longer period of time because of it. So you could say that meth is kind of like cocaine on cocaine.
Okay.
Okay. So history of cocaine, coca plants. History of amphetamines, a little different. Benzedrine was created in like the 1920s and 30s as an over-the-counter nasal decongestant, because you have to think that the same effects that constrict vessels, right? Increased blood pressure, constrict vessels.
I've worked in ERs where we still have like cocaine to treat nosebleeds. True. That's true.
Do you want to maybe tell me what those ERs are?
No, I don't. No, I won't publicly say it on a podcast. No, like I have seen like where like they like, I don't think they even make it that way anymore, but like some of these old hospitals like still have some.
What?
Yeah.
Are you sure?
Yeah,
Are you pulling something out of
no,
your
I'm
butt
dead
right now?
serious. I'm dead serious.
I don't think that's allowed.
I mean, it is still, you can't prescribe it. I would say, but you can't no, that's how they used to use it. Same way, like same.
Why
thing
wouldn't they have
saying.
gotten rid of an old man that's not legal to use anymore?
I don't know. I'm not the hospital administration.
I don't think I would have admitted that that's the truth.
Why? It was a medication for a long time. Until even like recently.
Just taking some notes here. Till recently?
Yeah.
No.
Yeah.
Benzedrine has not been used in a very long
Not
time.
Benzedrine.
What happened with Benzedrine, which is if you let me just tell the story.
Go ahead.
It was an over-the-counter nasal decongestant used in like the 1920s and 30s. And then what would happen is it had an addictive effect, because it would have basically, just like if you take Sudafed now, it perks you up, right? It's a sinus medication, but it'll perk you up because it has those effects. People would use it in World War II to avoid fatigue during battle. So the government was like, hey, use Benzedrine to stay awake and shoot straighter and be more alert. And then what happened was lots of soldiers would get hooked on it because it had highly addictive effects, and then you dealt with like Benzedrines. Fun fact, I'm reading right now the L.A. Quartet by James Ellroy, which is like what the game L.A. Noir is based off and stuff like that. It's like that like pulp detective in L.A., doing stuff like with the hat, and he's corrupt, and that kind of story was based out of that. All the old like noir movies like Chinatown and like Maltese Falcon is kind of based off of that time. Mm-hmm. In those books, lots of the cops and bad guys are hooked on Benzedrine because that was post-war.
Oh, okay.
They're hooked on Benzedrine, so they're basically taking a form of meth or coke, and then they're all amped up, and then they're like beating people up on the streets more.
As of 2020, the U.S. Food and Drug Administration has approved 2 cocaine hydrochloride products for medical use.
Yeah, but it's not like cocaine. It's like a version. It's distilled from the coca plant, but
it's still
not like
cocaine. That's cocaine.
All right, fine.
I'm not saying that like I'm like, hey, snort this in the middle of the ER, but like here's a nasal spray that happens to be cocaine hydrochloride. Yeah, that happens.
Let me know next time that you're in that area, and I will stop by and visit and have some nasal decongestion that I need. Half-life is way longer. There's lots of different types of amphetamines. There's meth, usually created from nasal decongestants like Sudafed. There's Adderall, which is used for ADHD. Concerta, which is ADHD. Ritalin, which you might have heard of from ADD, ADHD, and narcolepsy, which makes sense. Like, how do we treat narcolepsy? A version of cocaine to wake you up, right? Mm-hmm. And then Dexedrine treats narcolepsy too. So all of these things can be highly addictive if like properly, but like Sudafed, like you're not going to get hooked on Sudafed if you use Sudafed and then you use the process to introduce and turn it into meth. That's going to be a lot more addictive.
It's going to be more addictive, but it's not going to not be addictive, because like this is the problem. This is why they put Sudafed behind the counter, and you got to show your ID now because people were buying like tons of pseudoephedrine and then making methamphetamine. Right, this is before that, right? But like even Adderall like is a very effective medication for ADHD and that sort of thing. It is also very much abused. I mean, like I remember college, like people who did not need Adderall would get Adderall, crush it, and snort it because it's pretty much. I mean, like so, like it is addictive in its own way. Not as highly addictive, right? Obviously, like methamphetamine is extremely more highly addictive because of the dopamine effects and things like that. But these are, I will say, they can be dependent, like habit forming medications, right?
Well, and
just like caffeine.
Well, I was going to say, everything's relative. Like I stayed up late using caffeine to stay awake to study. it's different, but I'm just saying it's not that much of a leap to say there's people on my floor in college at Michigan State that would, like sell Adderall and get Adderall from people that had ADHD. They'd like buy it from them and then they'd
surprisingly, and this is not something I
whatever.
should probably admit, but especially going through pre-med,
That was probably heavily used, I would think, in med school.
like pre-med students were like, everybody was using it.
That's crazy.
'Cause we are like, I mean,
Except you.
I didn't.
Good.
I just drank holy water.
Oh, well. Does that work? I don't think you're supposed to drink that.
I'm gonna be honest with you, like you're not supposed to steal holy water either. So I don't know. But.
And here's the thing is if they made caffeine illegal, like if Diet Dr. Pepper was illegal, I would sell, produce, distribute.
You like moonshine, Dr. Pepper.
And I would think it was funny. I think that's the problem too, is I would think it was funny. Even if it got as serious, like, no, this is like modern day meth, like, and I got locked up for it, I would like be giggling in jail about that.
I mean, it's really interesting because like I think we live in a time, like everything is very relative, right? Like there was a time where alcohol was like prohibition.
Alcohol is a downer, 100%.
Right, but I'm saying like it was illegal at one point, right?
Yeah.
Cannabis in Michigan was illegal at one point. A lot of people went to jail for it, and now everybody can get it.
Mm-hmm.
And it even comes in fun gummy flavors, right? I mean, there are a lot of legislation out there to make things like psychedelic mushrooms and stuff legal to use, and I mean, like it's all from a legal standpoint, it's all relative. But in terms of from a medical side, like what it does to your body, understanding that is the most important part because everything can. I mean, again, like we talked about, even Tylenol. If you have to understand that in misused or like taken too much of can cause fulminant liver failure. I mean, like people die of Tylenol overdoses all the time, unfortunately. Like it's horrible. But like, so again, like just understanding the mechanisms of these medications is so important because then you understand when you get beyond the therapeutic effects and into those detrimental sides.
Well, I think what's really interesting too is that we're manipulating the chemicals that are already in our body with these cases. And I think a lot of people think, especially with illicit drug, you're introducing a chemical to your body and then that chemical's wreaking havoc or doing these things. And it's like, no, all that it does is make more of the dopamine that you have in you last longer in you.
And this is where like weird things like biohacking and stuff like come into like there are other ways to manipulate your like waking up in the morning and doing red light therapy like causes chemical shifts in these same chemicals in your body. I mean, like I said, there's lots of ways we can manipulate, and that's what medicine becomes, is manipulating what our body already does, either helping it do it better, helping the things that it's doing that are harming us to not happen. I mean, like we've talked about that a lot. Like really the practice of medicine becomes taking the body that is and optimizing it and helping it along type of thing.
Well, and so I think the follow-up question with a lot of this is, well, then why is cocaine and amphetamine so bad? And why cocaine and amphetamines are bad and have been made illegal and are dangerous is because it doesn't just give you elevated mood effects. It doesn't just wake you up a little bit like caffeine does. It's super habit forming. Mm-hmm. It increases your blood pressure and your heart rate and can get you to the point where you can have bust blood vessels and have internal bleeding and stuff like that. It makes you more aggressive. It alters your mood. You know what I mean? So those are dangerous things that you don't want, right? So that's why those are the illegal ones, right?
Like we found other things to do the medical things that cocaine did and really didn't really need cocaine medically anymore.
Exactly.
And then it's just we're using it for fun, which is fine until it starts to harm.
It's not.
No,
I'm going to go on record and say that Jason Sykes' opinion is it's not fine to use cocaine, people. Chris can say whatever he wants now.
I'm not saying it's fine to use cocaine. I'm saying it's fine to let's use cannabis as an example, right? Like a lot of people feel like it's perfectly fine to use cannabis for recreational uses because it doesn't, we found mainly all the time, harm people. Whereas cocaine was starting to harm a lot of people in ways that that's why THC no longer, cannabis no longer is illegal and cocaine remains illegal. It all has to do
and I think there's an argument though on the other side of that alcohol has harmed a lot of people, and there's a lot of people that believe that alcohol should be illegal, and it should be an illicit medication.
Right.
We should at least recognize that alcohol is a medication, and that it's not just a drink.
Right,
just something to think about. Cool. So treatment of OD and misuse of these, we would basically hit you with benzos. so here's where it's kind of effed up is how do we treat uppers? With downers, right? So we would treat you with we'd stabilize you as best we can. If your heart rate's going and you're bleeding, or if you're aggressive, we need to sedate you for your own safety and for ours, and we would sedate you with benzos.
Mm-hmm.
Anything.
And really benzodiazepines are kind of the only thing other than keeping people in a safe environment, keeping them out of harm's way, letting the medicine, treating the symptoms too, like lowering their blood pressure because of the risks of, heart attacks and things like that. It really becomes more protecting the body against the bad side effects of these illicit drugs. And again, benzodiazepines is really the only thing we have that can help, right? Like if you get up in the morning, you take a bunch of caffeine because you're sleepy, you stay up too late, but now you're really up, so you take a Valium to kind of calm yourself down, but now you're not really motivated, so you got to do some cocaine to bring it back up. You know what I mean? It's just kind of, just up and down.
And that's why like cocaine and meth too get far more dangerous if you're drinking with them, because then you're taking a downer with it, right? And you just kind of have to recognize that. One question that I get a lot is, how does ADHD, why is the treatment for something that makes you hyperactive a med that would be an upper that typically makes you hyperactive? And the reason why this works is that it increases your focus. So it's an upper, it's a stimulant. It doesn't necessarily make you hyperactive and distracted with that stimulus. It makes you hyper-focused. So people that struggle...
It actually calms people down if they truly have...
Right. If they have ADHD, they'll be more focused and calmed when they take that type of stimulant versus someone who doesn't, right?
Right.
So, cool. 2 other meds that I want to talk about. Ecstasy, MDMA, also known as Molly, which, did you know is an abbreviation for molecular?
I did not.
It speaks to like the purity of it. I didn't know that. But Molly, very chemically similar to stimulants, but also chemically similar to hallucinogens. So this is where we also start to get into hallucinogenic effects, where you get weird, trippy, things. So plays on dopamine, norepi, and serotonin again, but the increased serotonin will trigger arousal, trust, increased trust, better mood, more empathy, and then like emotional closeness, which is why you'll see it in the clubbing scene where people are all touchy-feely and they're dancing and they want to have like a psychedelic kind of experience with a hallucinogen, and they also want to have the dopamine effects.
You don't really get like hallucinations the way we think of hallucinations, but it does like...
if it's mixed with stuff, which it almost always is. So that's the big scary thing about ecstasy, is that like in the club scene, people mix in cocaine, people mix in meth, people mix in mushrooms and psychedelics and stuff. So like it is very hard to get clean MDMA.
You have to really trust who you're getting these things from. If like honestly,
just don't get them. Again, Jason Seitz is going on the record saying don't ever go get these.
No,
things.
I'm just saying that like.
But yeah, this is why it has become such a dangerous thing in the club scene, and why
mixing.
Yeah, like the government is really cracking down on it, because there's been very dangerous mixing that like they take them. Like you have meth with it, and then like the meth kills you on the spot because your heart explodes, and you thought you were just gonna have a nice little like sexy time, right?
What's actually interesting too. This is actually I talked to someone. This was on the opiate side when we were doing some stuff with the hospital I was working at in the opiate crisis side of things. But this was someone who had been addicted to like heroin and that sort of thing, and had opiate, and then they were in recovery and helping others get to recovery. And he actually said, he goes, it's actually very common. And this is actually, I think, common in I'm speaking to this comment was made in like the heroin space, but I think this is kind of like something that occurs where like people who deal in these medications and things like that, like sometimes purposely mix things in poorly so that people have
a certain percentage die.
Yeah, where especially when it comes to like heroin, which is again not a stimulant. We're not talking about that today, but like if someone dies from it, then it gets this idea that like, oh, that stuff must be really, really good.
Your customers think it's very potent, which means that
which is very like
it's scary stuff.
That's pretty scary. But
the most dangerous thing that gets mixed in with MDMA is the next thing that we're going to talk about, and that's bath salts. So bath salts. History between that, similar to cocaine, the cat plant, which is found in East Africa and Southern Arabia, would be chewed on. The leaves would be chewed on for mild stimulant effects. But now they're like, bath salts are scary, guys. Like, don't.
These bath salts are the things where like someone ate someone's face off.
Yeah.
Like that's bath salts.
Right. They're swallowed, they're snorted, they're smoked, or they're injected. They're called, I think it's based off the cat plant, so I think they're called, I don't know.
Cathinones,
or catinones. They can be deadly, like on the first hit. So can meth, but and there's really, really strong withdrawal symptoms from them. So depression, anxiety, everything on the opposite side of the stimulant, right? So you get all the happiness and the concentration and all that, and then on the opposite side, depression, anxiety, tremors, paranoia, Sometimes you'll have trouble sleeping because there's still
You can get
stimulant effects.
a
going on.
bad come down from MDMA too in the same way, where like it's like
Well, they say
impending
specifically
doom
that-
and like
Yeah.
and that's where people can harm themselves if it's really bad. You know what I mean? Which you got to be careful.
So again, how do we treat these things? We treat by stabilizing the patient, and then we use behavioral therapy for their addiction. And if we need to sedate them because they're aggressive, like in bath salts, if they're trying to eat your face off like a zombie, then sedate them with benzos. But don't get them hooked on benzos because that's a whole other thing. We'll talk about that in our downers. One thing that I'm not going to talk about, at least this year, I won't say I'll never talk about it. I will not talk about psychedelics because I started to write up a thing on psychedelics. I'm going to tell you right now, I don't sit on either side of the fence of it. Don't really care that much. Not something I'm going to do myself. Doesn't mean I condone it. Doesn't mean I don't condone it. But I don't want to deal with all of the comments that I was already getting just trying to investigate it into like, you have to do psychedelics because it'll change your life. With like, if you do I know someone who did psychedelics and then they killed their mother. Like, it's just like, it's all over the place, guys. I don't know. Do your own
Research.
on mushrooms. I don't know what to tell you.
Right. And that
Portobello's.
maybe that's a conversation we have about hallucinogens at some point.
Yeah.
Psychedelics and hallucinogens. But really what's interesting too, I think like the takeaway here, like these stimulants, obviously we understand, hopefully now you guys understand their effects on norepinephrine, dopamine, serotonin. They all have other aspects to them, right? Some of them have psychedelic hallucinogenic effects. Some of them have like, you know, sedative type, I don't know. There's like, so just recognize that like it's like almost a continuum, especially when it comes, like that was one thing that I struggled with when I was like in medical school and even as a physician, like trying to sort these out and group them. You really can't group them. Like if you group like hallucinogens separate from stimulants, all of a sudden there's overlap. And if you separate stimulants from, you know, I don't know, like there's another whole category there, but like you just have to like, there is some overlap. So you need to kind of understand what each medication does. But the resounding treatment plan is, again, if they're up, bring them down, right? Treat their actual physical symptoms, their hypertension, their angina, right? Their, you know, that type of thing. Keep them in a safe environment, keep them hydrated. Another thing with stimulants is that you can like run into like increased metabolism and metabolic rate, so you can get kidney dysfunction. You know what I mean? Like you speed up processes. You got to be careful there too.
With meth, especially, they're more because the half-life is so long and they stay in that hyperactive state for so long, their chances of being dehydrated, malnourished, you know, like having those like longer term symptoms for longer, like they get exposed for longer because the cocaine wears off, right?
Right.
The meth doesn't wear off for some time. So they haven't eaten, they haven't slept, they haven't drank anything. So they're, you know,
right, yeah.
apart fast.
So again, so treat the patient, not the medication they took, but understand what these medications do and what these chemicals do, so that you know what to look out for too, right? And again, really in terms of like bringing people down, it's really just benzos, right? Honestly, like I feel like fluids and benzos and keep them safe, and that's wait for it to go, right? That's kind of what you have to do. So cool.
All right. Hope you learned something. Check it out at guardiancma.com for a free credit. We will see you next time.
Sounds good.
Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPCE credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.